Participants, my name is Gavin McDonough, and I am the Educational Action Supporting Officer at ERN-EuroBloodNet, the European Reference Network for Rare Hematological Diseases. And it is my great pleasure to welcome you to the ERN-EuroBloodNet topic on focus on constitutional thrombocytopenia, which is an accredited European online educational program targeting health professionals organized by the ERN-EuroBloodNet and in partnership with the French Reference Center for Inherited Platelet Disorders and the French Constitutional Sorry about that. And the French Constitutional Bleeding Disorders Network. This program consists of a cycle of webinars focused on constitutional thrombocytopenia, developed in collaboration with three experts, Professor Marie-Christine Alessi and Dr. Paul Saultier from Assistance Publique-Hôpitaux de Marseille, and Dr. Mathieu Fiore from CHU Bordeaux. Before we start, let me share some home rules. Please note that the session is recorded and will be uploaded to the EBN e-learning environment. If you do not wish to appear, please turn your camera off and change your name on the platform. Also, please be kindly informed that your microphone is muted, ideally. If you have any question about the presentation, please write them in the chat and they will be addressed during the question and answering session at the end of the webinar. I will read those questions out loud so that everyone who watches the video in the future can hear those questions. Just in terms of accreditation, there'll be a survey at the end of the webinar, and please use your first name and last name that you used originally to register. And with that, today's webinar is on constitutional thrombocytopenia and bleeding risk by Professor Paolo Gresele. Professor Paolo Gresele is a full professor of internal medicine at University of Perugia, past president of the Italian Society on Hemostasis and Thrombosis, and the past chair of the Platelet Physiology Scientific and Standardization Committee of the International Society on Thrombosis and Hemostasis. And with that, it's a great honor to give you the floor, Professor.
Thank you very much, Gavin, for the introduction, and I wish to thank the EuroBloodNet for kind invitation to give this webinar and for organizing this series of webinars. I thank the French group, Marie-Christine, Paul Saultier, and Mathieu Fiore for this opportunity. The title that I've been assigned is Constitutional Thrombocytopenia and the Bleeding Risk. And indeed, the constitutional thrombocytopenias are a group of largely underdiagnosed and poorly known inherited disorders. So making the point on their bleeding manifestations and on their phenotype may be very important and relevant for their appropriate management. I have divided my talk into three parts. In the first part, I give a brief general introduction with definition, epidemiology, and some pathophysiological background. In the second part, I will give an account of what it is currently known on the bleeding phenotype of these kind of disorders. And in a third short part, I will briefly discuss their management. I don't have any conflict of interest related to this talk. So let's start with the definition. So inherited platelet disorders are a heterogeneous group of rare congenital hemorrhagic disorders associated with a reduction of the platelet number. So they are also called inherited thrombocytopenias, or an impaired platelet function. They are also called inherited platelet function disorders. And as we will see, several of them share these two characteristics. So they have both thrombocytopenia and an impairment of platelet function. They are generally considered disorder with a very variable bleeding diathesis and are largely heterogeneous in terms of molecular and genetic defect. And for a significant part of them, the gene involved in their pathogenesis is not known yet. The diagnosis of many of these forms is also cumbersome and sometimes require complex assays. So in terms of epidemiology, until around 20 years ago, these were considered as very rare disorder, and actually only the most severe forms were known. So they were considered even rather severe bleeding disorders. This is an epidemiological study carried out in 2012 in Italy, which established the prevalence of this disorder at 2.7 cases per 100,000 inhabitants. After this, however, in the last decade, there has been an explosion of the application of next generation sequencing testing for the diagnosis and the investigation of these disorders. So the number of this disorder has surely increased. And this is actually the current knowledge today of the genes involved in causing inherited platelet disorders. So there are 76 genes that have been identified as associated with inherited platelet disorder, and 47 of these are associated with inherited thrombocytopenias. So surely the number, as compared to what was known in 2012, is increased, but the exact prevalence nowadays is still not precisely defined. This kind of gene variants impair platelet number by different mechanisms, by disturbing megakaryopoiesis at the level of megakaryocyte maturation, a number of genes, by disrupting the ability of megakaryocyte to produce proplatelets, another number of gene variants. And for some gene variants associated with the thrombocytopenias, there is not yet the knowledge of what is the mechanism that generates thrombocytopenia. In order to understand the phenotype, the bleeding phenotype of this disorder, it may be useful to briefly recall the very crucial role that platelets play in the hemostatic system. Platelets are the first responder to a damage in the vessel wall. They recognize and adhere very rapidly to the damaged vessel wall. They release a number of molecules which recruit further platelets to the growing plug and form very rapidly a platelet plug, which interrupts the bleeding. But they are also involved in the activation of the blood coagulation system, which stabilizes the blood clot. And finally, once the integrity of the vessel wall has been restored, they also are involved in the regulation of the fibrinolytic process, which removes the no longer needed blood clot. Another function which is less well known, physiological function which is less well known of platelets, is their ability to maintain the endothelial integrity. And platelets do so by releasing a number of angiogenic and growth factors which stabilize the interendothelial junctions, and in this way contribute to render impermeable the internal layer of the endothelium in our blood vessels. Based on these physiological functions, it's easy to understand what are the mechanisms, what are the manifestations when the number of platelets is decreased significantly, or when the platelets do not function properly. And these are the typical mucocutaneous bleeding manifestations associated with thrombocytopenia. Petechiae, in particular, are considered a manifestation in which the loss of the endothelial permeability is largely involved. But of course, ecchymosis, purpura, gum bleeding, epistaxis, menometrorrhagia, and other manifestations are the typical manifestation of this disorder. Intracranial hemorrhage is a very rare condition associated with the most severe, rarely with the most severe forms. And the other typical manifestation are surgery or trauma-related bleeding. the severity of these manifestations and the frequency of this manifestation in thrombocytopenias is largely depending on the severity of the decrease in the platelet number. And this is a study systematic study in mice in which the platelet number was decreased progressively by increasing doses of an antiplatelet antibody injected in the animals. And systematically in these animals, the bleeding time was measured. And you see that although there is a trend to an increase with a decrease in the platelet number, a significant increase in prolongation of the bleeding time is observed only with very low platelet numbers. So below 7% of the baseline platelet number, and it becomes very important when the number is below 2% of the baseline normal platelet number. And these kind of findings in the animal are largely confirmed in humans. This is a study in patients, it's an old study, but still absolutely valid, in which the bleeding manifestation were correlated to the degree of thrombocytopenia in a group of patients with acute leukemia not treated with chemotherapeutic agents. So patients in which platelet decrease was due to a bone marrow insufficiency. And you see that the bleeding manifestations start to increase when the platelets go down to very low levels, below 20,000 platelets per microliter, you start to have significant bleeding manifestation, but even more and more significant when the platelets are below 10 or 5,000, 10,000 or 5,000 per microliter, which again is below 5 or 2% of the normal baseline platelet number. But of course, the bleeding manifestation are enhanced when together with the thrombocytopenia, you also have a platelet dysfunction. This is typically presented in this study in patients with immune thrombocytopenia, in which the decrease in platelet count and platelet dysfunction as assessed by flow cytometry were correlated to the bleeding manifestation as measured by a bleeding score. And you see that besides the fact that by progressively decreasing platelet number, the bleeding score increases, also the platelet dysfunction was largely involved, with the bleeding manifestation much more prevalent in those patients who had a platelet dysfunction associated with the thrombocytopenia. And this is important to recall because, as I alluded to at the beginning of my talk, the inherited thrombocytopenias are often associated with platelet dysfunction. So this is a list of the known inherited thrombocytopenias without platelet dysfunction and those which are associated with a platelet dysfunction. And you see that there are some very common forms like the ankyrin-related thrombocytopenia or the Wiskott-Aldrich syndrome or the RANKS1 FDP-AML disorder, which are, or of course, the biallelic Bernard-Soulier syndrome, which are typically associated with platelet dysfunction together with thrombocytopenia. So let's come to the second part of my talk. Let's see what is currently known about the bleeding manifestation of patients with inherited thrombocytopenia. And the way to assess the bleeding severity of a hemorrhagic disorder are two. The first one is to measure the history of spontaneous or provoked hemorrhage by using a bleeding assessment tool. So a standardized questionnaire which collects and grades the bleeding events in the history of the patient. And the second one is the systematic evaluation of the prevalence of excessive bleeding during invasive procedures. Let's go with the first kind of approach. This is a study that we have organized a few years ago on the systematic assessment of a well-established bleeding assessment tool, which is the ISTH bleeding assessment tool, a tool which has been established and validated for the investigation of the bleeding severity of patients with von Willebrand disease. Well, we applied this to 1,100 subjects enrolled by 43 centers around the world. And these subjects were divided into 3 groups: healthy control, so subjects with no evidence of any hemostatic alteration; von Willebrand disease type 1, in order to have a well-established group, a comparator group with a bleeding diathesis; and inherited platelet disorders. We had almost 500 cases of inherited platelet disorder, which were divided in inherited platelet function disorder and inherited thrombocytopenia. There were 286 inherited thrombocytopenias, and these 3 groups were well balanced for sex, median age, and for the small number of pediatric subjects included in the 3 series. And these are the results. So you see that von Willebrand disease has an average bleeding score of 5, which is in line with what was found in the previous study, which validated this tool for von Willebrand disease. You see that inherited platelet function disorder have a significantly higher average bleeding score, which is 9 compared to 5 of the von Willebrand disease. But this is what you obtain in patients with inherited thrombocytopenia. The average bleeding score is 2, which is, yes, significantly higher than healthy controls, which has an average 0, but it is only very mildly increased as compared to the healthy controls. In all the groups, females, as known, had a higher bleeding score as compared to males. Of course, within the inherited thrombocytopenia, there was some degree of variability, which with some form which had a very high bleeding score, like the Wiskott-Aldrich syndrome or the biallelic Bernard-Soulier syndrome, which are both conditions associated with a platelet dysfunction besides the decrease in platelet number. Others which had a mild, very mild bleeding diathesis, and very many important forms like the monoallelic Bernard-Soulier syndrome or the MYH9 related thrombocytopenia, which had a very small or no bleeding diathesis at all. Even in terms of median number of hemorrhagic symptoms or of the percentage of symptoms which were clinically relevant, the inherited thrombocytopenia behaved in a way which was less severe as compared to the inherited platelet function disorder and von Willebrand disease, and only mildly different from healthy controls. This study was a prospective study. So all the patients enrolled were followed up for 2 years, and the incidence of new bleedings were recorded. And here is what happens in a 2-year follow-up that again confirms the findings that I showed before. So the patients with inherited platelet function disorder had a very high incidence of bleeding events in the 2-year follow-up. This was followed by the von Willebrand disease group, the orange one here, and the inherited thrombocytopenia only slightly differed from the healthy controls with very little incidence of bleeding events in the follow-up. Of course, this was correlated to the baseline bleeding score. This is very evident in the inherited platelet function disorders, but also the inherited thrombocytopenia, those rare cases who had a high bleeding score at enrollment, on follow-up had a higher, significantly higher incidence of bleeding events. So let's come to the second way of assessing the bleeding severity in these disorders. So the systematic evaluation of the prevalence of excessive bleeding during invasive procedures. This is another study that we organized, which is a large retrospective study involving many centers who contributed 829 invasive procedures, 374 of which were carried out in patients with inherited thrombocytopenia. These were major surgery for around 60% of cases, dental procedures for 28% of cases, and minor invasive surgeries for 12.2% of the cases. And here is a list of the different types of invasive procedures that these patients received. The bleeding, excessive bleeding, was scored in 3 different ways: by the Bleeding Assessment Research Consortium score, when this was above 2, by the subjective evaluation of the surgeon who carried out the surgery, who said that it was excessive or not, and by a duration longer than 6 hours. And this is the combined incidence of an excessive bleeding score when any of these 3 ways of assessing excessive bleeding was considered. And you see that 25%, 1 every 4 procedures, was associated with excessive bleeding in patients with inherited platelet function disorders, while this incidence was much lower in patients with inherited thrombocytopenias. This was 13.4%. This must be compared with the healthy control subjects, so patients who did not have any evidence of a hemostatic disorder, who had in this study 3%, and from the literature up to 6% incidence. So is higher in patients with inherited thrombocytopenia, but certainly much lower than what happens in patients with inherited platelet function disorder. Again, here too, there was some variability among the different forms in terms of incidence of excessive bleeding, but you see that in general, the incidence of bleeding in patients with inherited thrombocytopenia was rather low as compared with the incidence in patients with inherited platelet disorder. For some of the inherited platelet function disorder, for some of the inherited platelet function disorder, incidence was up to 1 major hemorrhage after surgery out of 2 surgeries carried out. What were the predictive parameters for the incidence of excessive bleeding after surgery? Well, the first of all was the bleeding history of the patient. In this case, was calculated with the WHO bleeding score, and the higher the bleeding score, the higher was the incidence of excessive bleeding after surgery. But what is interesting that is that in inherited thrombocytopenia, of course, as expected, was the platelet count. And the platelet count, a cutoff that was associated with a significant rise in post-surgical bleeding, was 68,000 platelets per microliter. And this was associated with an odds ratio to have excessive bleeding of 2. So a 2-fold increase in the risk of major bleeding after surgery. Another interesting observation is that female gender was associated with a higher incidence of post-surgical bleeding. And indeed, in the BAT follow-up study that I showed earlier, the incidence of bleeding in the 2 years follow-up was significantly higher in females as compared to males. And this is probably in part due to the fact that females have a number of female-specific possibilities of hemorrhage, like menorrhagia, ovulation-associated bleeding, endometriosis, excessive bleeding at gynecological surgery, and the most feared complication, which is postpartum hemorrhage. Concerning postpartum hemorrhage, there is a large study, retrospective study, the PITA study, who assessed 296 delivery in 181 women with 13 different forms of inherited thrombocytopenia. And the overall frequency of excessive bleeding at delivery was 14.2%, and the overall frequency of major bleeding was 6.8%. And this must be compared with excessive the hemorrhage at delivery in healthy women without any hemostatic defect, which goes from 3 to 7%. So this increased bleeding is rather minor, not very important, not very incident. And of course, predictive parameters for this excessive bleeding in patients with inherited thrombocytopenia were the previous history of bleeding, again, WHO bleeding score higher was associated with a higher risk of postpartum hemorrhage, and the platelet count. Women with a platelet count lower than 50,000 microliters had a higher, significantly higher incidence of postpartum hemorrhage as compared with women with a number higher than 50,000 per microliter. Also, a sub-analysis of the SPATA study, of the surgery study I showed earlier, looking only at gynecological surgeries, it shows that indeed the excessive bleeding after surgery, gynecological surgery, is rather frequent in patients with inherited platelet disorder, but again, much more frequent in patients with inherited platelet function disorder as compared to the inherited thrombocytopenias. Before going into the management, it's important to remind one characteristic which is not the focus of my talk of today, but which must be recalled, and it is that a rather large number of inherited thrombocytopenia do not have as a clinical manifestation only thrombocytopenia and therefore bleeding, but they are considered such as predisposition syndrome. So they predispose to the development of other disorders, which very often during lifetime, not at birth, which may be quite important, and these disorders are bone marrow aplasia for the congenital megakaryocytic thrombocytopenia, the development of hematological malignancies for 3 inherited thrombocytopenia, which are here indicated, and the involvement of some other organs like kidney failure, hearing loss, the development of cataracts, and the alteration of liver enzymes for the MYH9 related disorders, sometimes very severe, with the kidney failure developing very early in life. So this kind of manifestation, when they develop during the life of the patients, may have an impact on the prognosis and on the survival of these patients, which may be much more heavy, much more important than the incidence of bleeding. Having said that, we go to the last and short part of my talk, which is the approach to the management of these disorders. And the approach to the management involves the measure to prevent bleeding or to treat bleeding, and the treatment of other defects in those forms which are predisposing to the development of other alterations besides platelets. Prevention of bleeding can be carried out with promispatic interventions, which include, of course, platelet transfusions, because the problem here is the reduced platelet number, but also with the use of pro-hemostatic agents like antifibrinolytic agents, including tranexamic acid or epsilon aminocaproic acid, the use of desmopressin, and in some specific forms, the use of recombinant activated factor 7. Then the other possibility is to increase platelet count, again, platelet transfusion, as said, but also for a few forms, splenectomy, because, for instance, the Wiskott-Aldrich syndrome, but also platelet type of biliary disease, are associated with the shortening of the platelet survival in the circulation, and splenectomy has some impact, positive impact on that. The use of the hematopoietic stem cell transplantation, and this is reserved to this very severe form, Wiskott-Aldrich syndrome, CAMT, and biallelic Bernard-Soulier syndrome, and gene therapy, which has been adopted with success in the Wiskott-Aldrich syndrome. And as we will see, I will come back to this, also L-Thrombopag, a TPO receptor agonist, has shown to be effective for the preparation to surgery or other condition in patients with some forms of inherited thrombocytopenia. The treatment of other defects involves the treatment of kidney failure, which may be delayed by the use of ACE inhibitor or angiotensin receptor blockers, the treatment of the deafness with cochlear implantation or ocular defect with cataract surgery. These are the treatment options specific for bleeding, antifibrinolytic agents, which can be used locally, like for instance for mouthwashes, or systemically, and they use very effective usually to arrest or prevent epistaxis, gingival bleeding, or menorrhagia, or for the prevention of bleeding in minor surgery. DDAVP, which can be given either intravenously or subcutaneously or by nasal spray, which is efficacious in the preparation to invasive procedure or minor surgery, but is contraindicated in some form like platelet type umbilical disease. Platelet transfusion, which should be reserved only to conditions in which other agents have failed, for the risk of alloimmunization and also for the infectious risk that platelet transfusion may carry. Recombinant factor 7A, which is approved for the treatment of Glanzmann thrombocytopenia, refractory to platelet transfusion, but is being used also for biallelic Bernard-Soulier syndromes and off-label for some other cases. And finally, L-Thrombopag, which has been shown to increase the platelet count within 10 to 15 days from starting the intake in patients with the MYH9 related disorder, but also in patients with the Ankyrin related disorder or the Wiskow-Taldes syndrome or other two forms of inherited thrombocytopenia. This is the study, the SPATA study, and the attitude used by centers around the world for the prophylactic antihemorrhagic preparation to surgery in patients with this disorder. You see that prophylaxis was given in 80% of the procedure carried out in patients with inherited platelet function disorder, but only in 20% of the procedures in patients carried out in patients with inherited thrombocytopenias. It was very effective in reducing the bleeding associated with surgery in patients with inherited platelet function disorder by reducing by 1/2 the incidence of bleeding in those patients in which it was carried out, the prophylaxis. It was less evidently effective in patients with inherited thrombocytopenia. And indeed, this is the prophylactic antihemorrhagic preparation of inherited thrombocytopenia in those 20% it was in which this was carried out. This was carried out mostly with platelet transfusion and second with antifibrinolytic agents. But the effectiveness of this approach in prophylaxis was not very clear. What was instead very clear was that when there was a bleeding and there was an emergency treatment of the surgery associated with bleeding, platelet transfusions were very effective. There was no success in reducing or blocking the excessive bleeding associated with surgery in these patients. So this is an approach that had been proposed by Patrizia Norris, a colleague who has studied very much this kind of patients. When there is a bleeding in a patient with inherited thrombocytopenia, if it is life or organ threatening, or it is a bleeding in a critical site, please proceed immediately with platelet concentrates in order to stop it. If there is another bleeding, use initially local measure or tranexamic acid, antifibrinolytic agents, or desmopressin, or their association, and only if there is no response, use platelet concentrates, for the reason of limiting the use of platelet concentrates in order to not evoke alloimmunization and not have the patients running the risk of contracting some infection through the blood transfusion. And if there is no response to platelet concentrates, then use as a last option recombinant factor VII activated. So in conclusion, inherited thrombocytopenias are an heterogeneous and continuously expanding group of platelet disorder. They may be asymptomatic, sometimes completely asymptomatic, infrequently are severely hemorrhagic, but some form may be associated with bleeding, especially during invasive procedure and childbirth. Inherited thrombocytopenia are rather often associated with syndromic manifestation, which may severely affect prognosis, and this must be well known and considered in the management of these patients. And advances in treatment have made the management, the overall management of this disorder more effective in the last few years. Just have to thank for some of the data I presented, the people of my lab in Perugia, Loredana Buri, Emanuela Falcinelli, and Giuseppe Guglielmini and Maria Mezzasoma, who contributed to many parts of our studies, the ISTH SSC platelet physiology, who organized some of the studies I coordinated, the Italian registry of MYH9 related disorder established by Carlo Balluini in Pavia, the Bridge and Thrombogenomics Consortium led by Uwe and Catherine Frison, and for grant support, Teleton for some grants that contributed to carry out these studies. Thank you very much for your attention, and I'll be happy to take questions.
Thank you very much, Professor, for your presentation. That was wonderful. We do have a couple questions, and I encourage everyone in the audience to ask questions if they have them in the chat. We'll start off with the first question from Perla Bandini. Thank you for the great presentation. I have some questions. Can IPD be considered as bleeding disorders, even in some patients that are asymptomatic? And the second question, an IPD with decreased platelet number should be classified as thrombocytopenia, even if there is a functional platelet alteration.
Well, thank you for the question. The first question is probably yes, because despite the fact that these patients may be completely asymptomatic from the point of view of their bleeding diathesis, these are still patients who have a platelet count which is lower than normal, and which may decrease and reach critical levels easily or more easily than in a normal subject. So I think that these patients must always be regarded with attention, because with a concomitant infectious disorder or with a condition which may, a critical heal or a condition that may decrease platelets in every kind of patient, this may reach a critical level of thrombocytopenia more easily than a patient starting with normal platelets. So I believe that in general, they must be considered with attention from the point of view of the bleeding risks, even those who do not have any bleeding manifestation. Concerning the second question, this is a matter of classification, and there is not an official and shared classification of these disorders. So I believe that it is very important to have a clear understanding of whether the disorder you are dealing with, the patient you are treating, has a disorder which involves a platelet dysfunction or not. Because as we have seen from these studies, the prognosis in terms of bleeding risk and also the risk associated with invasive procedure or trauma is much different in these two conditions. So I would try as much as possible to classify these patients as prevalently inherited thrombocytopenia, so those in which the main manifestation is only the decrease in platelet number, what we know platelet dysfunction, and prevalently platelet dysfunctions, and those in which the platelet dysfunction plays a very, very important role in their bleeding manifestation.
Great, thank you for that answer. We also have a question from Professor Fiore, who was once again one of the experts behind this series. Do you have any experience with the use of RFV11A in BSS?
No, I personally have not used recombinant factor 7A for Bernard-Soulier. Of course, we are speaking about the biallelic Bernard-Soulier syndrome, but there are several reports in the literature, and it appears that it has been useful in some of these cases. So I believe that it is an option, as I indicated in the flow chart that I showed near the end of my presentation. So when you have a patient with a severe bleeding and that does not respond, including in Bernard-Soulier syndrome patient, does not respond to platelet transfusion, then adopting recombinant factor 7A can be surely a way of approaching the problem. Of course, it must be considered it is off-label, because the only on-label use outside hemophilia, acquired hemophilia, is Glanzmann thrombasthenia.
Great, thank you very much. We have a number of compliments on your very clear presentation. We also have a question from Professor Marie-Christine Alessi, who is once again one of the experts behind this series as well. Thanks a lot, Paolo, for participating to this webinar. What is your opinion on V11A as the first therapeutical option for delivery in IFPD?
So again, the question is about the use of recombinant factor 7A. I believe that it is indicated in patients with Glanzmann thrombasthenia, definitely. Patients with Glanzmann thrombasthenia have a very high risk of postpartum hemorrhage. Sometimes this postpartum hemorrhage is absolutely catastrophic and very difficult to arrest. So especially depending on the previous history of the subject, so what have been the bleeding manifestation, because even within the Glanzmann thrombasthenia group, there is variability in the bleeding manifestation, and the bleeding history is very crucial for predicting future events. So based on the previous bleeding history and on the possible complications of delivery, so the fetus position and many other, the dimensions of the fetus and so on, and many other considerations, it may be indicated to use recombinant factor 7A upfront, so before that the delivery, in order to be sure that you will not start a catastrophic bleeding event, which is then very difficult to stop. For other conditions, I would really limit the use of recombinant factor 7A only into those patients who have either really obstetric indications for a very complex, very difficult delivery, or those who had a history of very severe bleedings in previous invasive occasional trauma or other deliveries.
Great, thank you once again. We have an additional question. Thank you. I understand that the bleeding score in WAS patients is more important than XLT patients. Do you know why? Because of platelet function defect or immune thrombocytopenia?
This is a very good question, and is a question that raised also our curiosity, but it is it is indeed true that the bleeding diathesis appear to be more severe in the viscotolerance as compared to X-linked thrombocytopenia, although the genetic defect is substantially identical. Viscotolerance syndrome is much more severe as compared to X-linked thrombocytopenia for the syndromic manifestation that these patients have high risk of developing lymphoproliferative disorder, infection. They usually die by 20 years of age if not treated, while X-linked thrombocytopenia do not have these associated problems. Probably the platelet function defect is more severe, and usually, but not always, the drop in the platelet count, so the decrease, the severity of the thrombocytopenia is greater in patients with Aldrich syndrome as compared to the X-linked thrombocytopenia. For the rest, there are no differences known or that I know that can explain the different bleeding diathesis.
Great, thank you. And just a general reminder that we have time for more questions as well if you'd like to enter them into the chat. We have another question. Thank you for your great presentation. Do you have any recommendations regarding the use of HLA-selected platelets to minimize the risk of immunization, for example, for elective surgery? Do you use them for specific diagnosis, PSS, GT, other?
This is a very well taken question. It is very important. I strongly recommend to have a good interaction with the transfusion center, because when you ask for platelet concentrates to treat these patients, there is always some discussion with the transfusion center. Very great discussion when these patients do not have a severe thrombocytopenia, like in Bernard-Soulier, biallelic Bernard-Soulier syndrome, or even more, of course, in Glanzmann thrombasthenia, where the platelet number is perfectly normal. And even more if you then ask for specific requirements on the blood transfusion. But I always insist to have HLA selected and AB0 compatible platelet transfusion, and whenever possible to have them LEGPO reduced in order to avoid the risk. There is a very, very rare risk, which is the graft versus host reaction triggered by transfusion in immunocompromised patients or fragile patients. And for instance, their leukoreduction is very important. So I strongly recommend to insist with the centers, with the transfusion center, to have HLA selected platelet concentrate and possibly AB0 compatible and leukoreduced, in order to avoid side effects which go from alloimmunization to, as I said, graft versus host reaction, or any kind of desensitization to the transfusions. And this must be kept very well in mind, because the patients who require platelet transfusion are usually the most severe, which are, as we have seen, those who will bleed again in the course of their life, and they will need again platelet transfusion. So selecting platelets according to these specificities reduces the risk of immunization and reduces the risk of losing a very important weapon to fight bleeding in these patients.
Great, thank you. Once again, this is a great opportunity. Oh, we have another question about the use of desmopressin. Any recommendation about dose, context, repeated doses?
Desmopressin, thank you for the question, and it's a perfect question. Desmopressin is a useful agent, not only for von Willebrand disease, where it has been established, and where it works because it releases von Willebrand factor from his stores in our endothelium, but it is also, let's say, a mildly panhemostatic agent, which works probably through other mechanisms besides the increase in von Willebrand disease, in the Willebrand factor. So I think it's a very useful agent. It's effective, definitely effective in a number of inherited platelet disorders, but not in all of them. For instance, again, one of the most severe, Glanzmann thrombasthenia, which is platelet dysfunction, is largely insensitive to desmopressin, but many of the others respond to desmopressin. So it's an attempt to be made, and I usually use it by intravenous route infusion in 15 milliliters of physiological solution at a dose of 0.3 microgram per kilogram of body weight. Usually I give it in the first day of surgery once every 12 hours, so morning and evening, and then I give it every 24 hours for a maximum of 3 to 5 days. After that, there is a kind of tachyphylaxis, and this agent should no longer be used. So if you need longer prohemostatic action, then after 3 to 5 days, you have to use other means of obtaining hemostasis.
Great, thank you for that answer. We have another question. Thank you for this excellent webinar. In severe isolated thrombocytopenia, do you always do bone marrow assessment to exclude acquired thrombocytopenia causes? Also, when you suspect of IPD, do you use techniques such as flow cytometry for platelet glycoproteins, immunofluorescence for cytoskeleton proteins for both?
No, I thank you for the question. No, I don't always prescribe or carry out a bone marrow assessment, because when you have a very clear phenotypic diagnosis, or when you have made a next generation sequencing and you have a very clearly established diagnosis, not required to have a bone marrow assessment. So many of these forms can be diagnosed with a chart, with a next generation sequencing chart now in a first approach at NGS, based of course on a previous careful clinical assessment. If you have this clear diagnosis, there is no need of carrying out a bone marrow assessment. So I think that in the diagnosis of this form, what is absolutely crucial is to carefully evaluate clinically the patient, his personal and family history, and to look at the blood smear, which is very important in many of these forms. Some of these forms can be identified at the first sight in a simple blood smear by an expert person. MYH9 related disorder, which is one, if not the most frequent inherited thrombocytopenia, or Wiskott-Aldrich syndrome, just can be caught immediately, just simply looking at the size of the platelet on the blood smear. In cases in which you have forms of thrombocytopenia, which may be immune thrombocytopenia or an inherited thrombocytopenia, and you don't have a genetic diagnosis, or the phenotype is not clear also in the lab, then it may be useful or it may be required sometimes to carry out a bone marrow evaluation. We do carry out the evaluation of platelet glycoproteins by flow cytometry, and we carry out a number of studies according to what is the guidelines for the diagnosis of these disorders, which have been published by the ISTH in 2015, which is a multi-step approach, which involves initially blood smear assessment, light transmission obligometry, flow cytometry, and the study of platelet granules by different techniques, usually using this multi-step approach. In 1 or 2 steps, you reach a diagnosis.
Great, thank you very much. Perhaps in order to respect the timing of everything, that will be the last question. I just wanted to take a moment, I'll put it in the chat, to suggest that you join for the next topic on focus, which is benefits and limitations of high throughput sequencing for the diagnosis of constitutional thrombocytopenia by Professor Kathleen Freyson on July 3rd. So in a couple weeks here. But I just wanted to take you a moment and thank you, Professor Gresele, for your presentation. And I'd also like to take a moment to thank the 3 experts behind coordinating this as well, and for the engagement of the audience and all the questions. It seems like perhaps there should be another session given the interest and the level of expertise. So it's wonderful to be a part of this, and thank you all for joining. I don't know if you have any final words, Professor, but...
It's been a great pleasure. I think that the discussion shows that there is interest and there is a great need of improving the knowledge in these rare disorders, which are much less rare than what we thought before, and which on one hand are opening very great windows on the understanding of the hemostatic function and the role of platelets in physiology and pathology, and on the other are really the new knowledge are leading to improvement of the management of this patient. And I believe that this kind of international initiatives are very important, because it's only making network and making a strong interaction among people who are interested in this disorder, and making culture and diffusing the knowledge on these disorders, that we can improve the management of these rare but not so rare patients. Thank you very much to the organizers, and thank you very much to the French experts who organized the meeting and who participated in the discussion today.
Yeah, thank you very much. Perfect. Thank you all for joining. Have a wonderful evening.
Goodbye.